When should HIV doctors hand off psychotropic drug management to psychiatrists?
Getting psychiatric management for HIV patients has been difficult because of resources. I tell HIV doctors they should be familiar with treating major depression, the commonest problem in our patients that need psychiatric medication. It's about a third of patients have major depression in an HIV clinic over time. The medicines are fairly easy to use. Some of them have some drug interactions, but most of them don't really have significant interactions with our medications. So treating with antidepressants is easy. It gets harder when you start talking about treating things like bipolar disorder. We're using lithium and neuroleptics and mood stabilizers. Those are more uncomfortable for HIV doctors. Getting a psychiatric resource in the clinic is incredibly helpful because you can walk down the hall and say, what would you do? And then I tell HIV physicians to call me for help when they have a patient who's bipolar, manic, bipolar and initiating new treatment, so a depressed person who is bipolar, patients with schizophrenia and psychosis. Patients with suicidal feelings of any sort should be evaluated by an expert. Patients who seem confused or delirious, and patients with really complex pharmacology. Those are patients where you really want to get some expert input from somebody who's managed a lot of patients. That person doesn't necessarily have to be a psychiatrist. It can be an HIV doc who's very interested in psychiatry. But having that resource is incredibly helpful in those patients.